Welcome to Boston Children's Answers Parentcast. I'm your host, Jennifer Arnold. As a doctor and a mom, I'm passionate about helping kids stay happy and healthy. So join me as I chat with other Boston children's experts to find answers for you and your family. Hi, everyone, and welcome back. Today, we're diving into a critical and often misunderstood topic, childhood diabetes. Diabetes is a condition that affects millions of people worldwide. And as you can imagine, for kids, it can be even more complex, from diagnosis and symptoms to treatment and the impact not only on a child's health, but also their emotional well-being. As always, let's start off with our parent question.
Hi there, I'm Mary. I have type 1 diabetes and am pregnant with our first child. I was wondering, is diabetes hereditary? And if so, how will I know if my child has it?
Thank you so much, Mary. I, as a neonatologist, get this question a lot about whether or not a condition might be hereditary. What's important to know, though, about diabetes is whether or not your child has it, it can be managed. And in fact, today we're going to talk all about the complexities and how to optimize care for kids with diabetes. And here to help us talk about that today is Dr. Katharine Garvey. Dr. Garvey is an endocrinologist here at Boston Children's Hospital. She's also director for our diabetes program and clinical chief for diabetes here at Boston Children's. Thanks for joining us today, Dr. Garvey.
Hey, Dr. Arnold. Thanks for having me.
I'd love to start off with helping our listeners understand really what is diabetes.
Yeah, so diabetes is a condition where the blood glucose or the blood sugar is too high. It can happen for different reasons. And the top reasons really would be that the body isn't making insulin or isn't making enough insulin, or the body's not responding to insulin or is resistant to it. Whatever the cause, we teach people to live healthy lives with diabetes and take care of it because over the long term, it can damage the organs.
Yeah, so it's really a concern related to blood sugar and blood sugar levels.
Exactly.
So I know we're going to talk a lot about really what that means for the body and treatment, but as an expert endocrinologist who specialized in this specific population, how did you find that passion? How did you get into this field?
Yeah, it's a great question. I went into pediatrics because I was always really captivated by taking care of the whole family and taking care of children at different stages of development. And when I was a pediatric resident, I found myself increasingly drawn to diabetes. I found the physiology fascinating, the way it's closely tied to what people are eating and how it needs to be managed. And it has so many points in the day where it really requires someone to stop and think about how they're going to manage it. So much complex decision making. And because of that, it really requires a lot of education. And that always appealed to me because I was a teacher before I went to medical school. And so really enjoyed teaching and teaching kids and really thinking about how each different patient and family requires a different approach and making diabetes fit into their lives and also starting to really chip away at the complex education required.
Wow.
And then once I was already down this path and had chosen to be a diabetes specialist, I did end up having a child diagnosed with it. And so that has really only strengthened my resolve and really humbled me. Having a child made me realize you have to educate the teachers and the coaches and the babysitters and the grandparents and all these other people in the sphere of a child's life. They all have to know basics at the very least about how to take care of this.
So who better than to take care of kids with this condition than a parent who also has a child with this? That experience that you have probably brings so much to the table for your patients because you've learned things that you don't learn in training or in a textbook. I also love teaching too, so I get why you like diabetes. I didn't get involved in teaching until after medical school, but I think teachers are the best. So the best providers are also great educators.
Absolutely.
As we think about helping to understand diabetes, could you explain to us what are the types of diabetes?
Yeah, of course. So if you walk into an adult clinic, the breakdown of types of diabetes would be very different from what you find in pediatrics. In children and teenagers with diabetes, the most common is type 1. Type 1 diabetes happens when the immune system, for reasons that we don't fully understand, attacks the beta cells in the pancreas, which are the cells that make insulin, and destroys them. And so people with type 1 diabetes simply don't make insulin. They lose that capability, although otherwise they're healthy. The peak age of diagnosis is 10, and About half of people are diagnosed before age 10.
Okay.
Now, type 2 diabetes in pediatrics happens after the age of 10. The peak diagnosis is around 16, and then as you move into adulthood, it gets higher and higher from there. So just to give you some grounding, type 1 diabetes is about 1 in 450 kids and teenagers, and type 2 is 1 in 1,450.
Wow. So there's a big difference there in terms of the prevalence of these two types.
Exactly. And so type 2 diabetes happens when the body makes insulin, but for a variety of reasons can't respond to it well.
So I'm wondering if you could share a little bit about the causes in general for type 1 versus type 2.
Yeah, of course. With type 1 diabetes, it's autoimmune. So there are factors that are somewhat genetic. And I say somewhat because it's not always clear. For example, identical twins who have the exact same DNA over the span of one's life, about 65% of identical twins will ultimately, by age 65, also have diabetes. But not all, right? So even if you have the exact same DNA, you don't 100% of the time get type 1 diabetes.
Which clearly makes you think it's got to be multifactorial, right?
Exactly.
So lots of things.
Exactly. So there are also environmental factors, viruses, for example, or potentially certain triggers in foods, but they're usually triggering someone who has some kind of a genetic predisposition. So just to provide some more grounding for the case that you mentioned at the beginning or the question from Mary, she has type 1 diabetes and is asking about her child. So the risk of a general child in the population coming down with type 1 diabetes would be about 0.5. But in a first-degree relative, it could be up to 5. But that's it.
5%.
Mm-hmm. Mm-hmm.
I mean, that's
So
not a tremendous number.
It's not a tremendous number. Of course, it feels like 100% if it happens to you.
Of course.
But by the numbers, it's a 10-fold increase, but it's still a very complex disorder with a lot of variables. And so we're not dealing with something where we can cite an exact risk. When we check their blood for something called antibodies, that tells us that they have autoimmunity against those beta cells in the pancreas. And it tells us in someone with diabetes that it's likely type 1. It can also tell us in someone without diabetes yet if they may be at risk for getting type 1. But it's that autoimmunity with the antibodies that really points us in the type 1
Type
direction.
1. That's that specific differentiator.
Exactly. In addition to age, in addition to certain things about the diabetes that may point us in that direction. Now with type 2, just getting back to the genetics, that actually tracks very strongly in families. And to go back to our identical twin example, up to 90% of identical twins will have type 2. So if anything, it's more tracked in families, but it also is very complex and is not a single gene and tends to involve a series of genes, and also obesity, again, is a huge factor in type 2 diabetes. Type 2 diabetes also tracks more Hispanic and Latino persons in Black individuals, whereas type 1 is more prevalent in non-Hispanic white individuals of European origin. So there are definitely population-based characteristics as well.
A lot to think about when you're trying to differentiate if a child may have type 1 or type 2.
We think about age, we think about antibodies, we think about whether or not the child has obesity, although people with obesity can get type 1 diabetes, right, and can get it as teenagers. And so I really bring that up to say that sometimes in the beginning, we're not quite sure what kind of diabetes somebody has. And we have to rely on the antibody testing, but also follow things out over time. And sometimes we can pick up more clues as to what's going on.
So it seems like the diagnosis is a little complex, but maybe before we talk about that, we should talk about what are the signs and symptoms that a parent should be aware of.
Whatever the cause of diabetes, it's going to cause high blood sugars. And once they get past a certain level, you'll start getting symptoms. The most common symptoms are increased urination and increased thirst. Sometimes families will say she's been drinking constantly and peeing all the time. Sometimes waking up in the night to pee can be a key symptom, or bedwetting, especially in someone who was previously toilet trained. Other symptoms could include fatigue, weight loss, sometimes things like slow wound healing or yeast infections. But I think the biggest thing to really drive home is not to miss those symptoms of increased thirst and increased urination.
I remember when I was a pediatric resident back in the day, we would have patients come in and their blood sugar was so high, they had diabetic ketoacidosis. And when you started to take the history, this was their first presentation of diabetes, parents would not have realized until that moment that, oh, yeah, they have been drinking more. They have been waking up at night to go to the bathroom or having bedwetting. Any advice for families who are thinking right now, is this something to worry about?
Yeah, it's a great question. And I'm glad you brought up diabetic ketoacidosis. Now, that's an end result of not having enough insulin in the body, or really almost zero insulin active in the body. Most of the time, that's a sign of type 1. And here at Boston Children's, about 30% of our newly diagnosed kids with type 1 diabetes present that way. And people in diabetic ketoacidosis have vomiting and are very sick, as you know, and need the ICU. And so you're exactly right. You want to catch it before it gets to that point. And I think the biggest advice would be to clue in to the signs of increased urination and thirst. Now, that's not always easy depending on the age of the child. If you have a teenager, who of us knows, if they're going to the bathroom more, getting up in the night to pee? I think in a young child, it's easier. And so I think paying attention to those symptoms, but also if things do progress to the point of vomiting, for example, really asking the right questions. We ask if someone's sick, are they still urinating? Are they still drinking?
It's a sign that you're not
That's
dehydrated.
a sign that they're not dehydrated, so everything is okay, but everything might not be okay.
Yep.
And so it's really just getting the awareness out that most of the time people are coming in with diabetes that's far enough along that I think if they had known that these symptoms were diabetes, it would have pierced the consciousness enough. They've shown in multiple places that public health campaigns really do decrease the incidence of DKA at diagnosis.
Yeah, because the goal is earlier recognition so that you can prevent a child from going into diabetic ketoacidosis because of how serious it is. Talking about diabetes, how prevalent is it really in the U.S.?
It's really prevalent. About 38 million Americans have diabetes, period. And then if you really drill that down to individuals under age 20, it's about 350,000. About 85% of diabetes in kids is type 1.
It's type 1.
Whereas in adults, the majority is type 2. Type 1 diabetes after asthma is the second most common chronic pediatric condition. 1 in 400, 450 is really common.
It's not a rare disease, and it's something that diagnosis and treatment is so critical.
Exactly. And because of the large size of the population, the complexity of the management is challenging, and it's really important to bring people like school nurses onto the team. But then the next thing is if we think about preventing type 1 diabetes or doing new treatments, how do we do that in such a large population? This is not a small niche chronic illness. We're talking about hundreds of thousands of kids.
Wow. Well, I definitely want to come back to that because I think when we think about innovation in the future, that's something that I think everyone would want to know more about where it's at today. But as I think back, going back a little bit, so say you have concerns that your child may have signs and symptoms that we talked about. How is diabetes diagnosed?
When people are coming in with symptoms, usually a blood glucose is tested. That can be done with a finger stick or through a blood test where they take blood out of a vein. It can be done first thing when people are fasting or really anytime. That we call it random blood glucose. And there are criteria for diagnosis of diabetes based on those numbers. Another really helpful test that we use all the time is called the hemoglobin A1C. What that is a test that tells us, on average, over the past 2 to 3 months, what has the blood sugar been? It's basically telling you a percent of the sugar impact on the red blood cells. And we have criteria for diagnosing diabetes based on that too.
Well, that's definitely something that I know in the adult world. My own physician is always making sure we keep an eye on.
Exactly. And not only do we use it to make the diagnosis, but then once people have diabetes, it is a really important way that we track it.
So I would imagine if you have symptoms or concerns, you should see a specialist, right? Or talk to your pediatrician first.
I recommend if people have any concern about diabetes, talking to their pediatrician or a pediatric practice first. That's how most of our referrals come in.
That's good to know for our parents who are listening out there. So let's talk about treatments. We've talked about diagnosis, signs and symptoms, how common it is, which is surprising for our parent, Mary. If her child does have diabetes, what are the treatment options today? What should parents be aware of?
The treatment options are also going to depend on the type of diabetes. And type 1 versus type 2, again, is an easy way for us to split it. So type 1 diabetes, they don't make insulin and they can't survive without insulin. So that insulin has to be replaced, which unfortunately is not easy to do. In type 2 diabetes, we're usually dealing with more of a resistance to insulin that is coming in many cases from obesity, as well as genetic factors. So we really target lifestyle changes. It's so important to try to reduce weight, to implement changes in the diet. And we usually add medication as well. One that's very common to use is called metformin. And then there are other medicines that are very popular and often discussed, like Ozempic, the GLP-1 agonists, or even insulin sometimes. But the difference to really understand for families is type 2 is multiple options, lifestyle, oral treatment, maybe some injections, maybe insulin. But in type 1, while diet and exercise are important, everything centers around giving the insulin back, and there's no way around that.
Because the body just doesn't make it.
The body just doesn't make it.
It's not a resistance problem that you can maybe overcome.
Exactly.
It's now that it just doesn't exist.
It has to be there. And in fact, before 1921, when insulin was discovered as the treatment for type 1 diabetes, people usually didn't survive.
Yeah. So we've come a long way from there. If we focus a little bit deeper dive on type 1 diabetes, knowing that it's more common in kids, how do we give insulin?
It's complex for a couple of reasons. The first reason is because the only way we can give it is with a shot or with an insulin pump under the skin. For adults, they're now coming out with things like nasal spray, actually, for insulin replacement, which is really interesting and is being studied in kids. But even that would not be the mainstay of treatment. The mainstay is injecting insulin. And so that's one reason why it's hard. There's a lot of supplies involved, a lot of technique. The second reason is that it's so tied to food. And what insulin does is it allows the body to take the fuel coming in with the food that you're eating and use it. And so if you don't have insulin there and you eat something with a lot of energy, a lot of carbohydrate, it will just come out in the urine. Your body can't use it. And so what that ends up meaning is that every time you eat, you have to make a series of decisions about how you're going to do the insulin. And it's a lot. It's a lot of burden.
I understand you're a camp doc for a summer camp for kids with diabetes, and I've done that once before, and I just remember it's complicated to calculate what dosing of insulin a child might need around meals.
Yeah, absolutely. That's an example of where you see it with just so many children eating food at the exact same time. But basically, when we think about type 1 diabetes, there are two things we have to be aware of. There's the fact that insulin has to be present 24/7 at all times. And we get that done with either a long-acting shot people take once a day, or people wear an insulin pump that is giving a rate of insulin in the background every hour.
What we call a basal rate,
basal
right?
rate. So either if they're on shots, they have a long-acting insulin shot doing that job. If they're on a pump, it's all short-acting, but it's going in that basal rate. Then on top of that, every time someone eats, they have to do the other job of the pancreas, which is put out the insulin to match that food. So for example, if you were going to go pick out a muffin, you would need to find out how many grams of carbohydrate were in that muffin. Let's say it's 60. Then if you were on shots, you would need to do math to figure out, okay, this is what my doctor says my body needs for carbohydrates. For example, 1 unit of insulin for 10 grams. And this muffin is 60 grams, so that's going to be 6 units. Let me inject that, ideally 15 minutes before I eat the muffin, so the insulin will be ready.
So you got to plan ahead.
You got to plan ahead, and then you can have the muffin. And then let's see how that goes.
And you still have to monitor, right, to see if that works.
Exactly. It may or may not work.
It's a lot for a kid.
It's a lot.
And a parent.
If you're on an insulin pump, you could tell your pump 60 grams, and then the pump would give the 6 units. But you still have to go through that process.
You're still thinking. You're still doing the calculation.
It's still intentional. And then you have to do that every time you eat forever.
Yeah.
And if you don't, then you're going to have those symptoms of feeling high and having your blood sugar be out of control. So that's the mainstay, is long-acting or basal insulin and then extra for food. And then we also teach people how to give extra to bring down a high should it happen. All of this has to be guided by glucose monitoring. So whether that is with finger pricks that we've all seen people do, or with something called a continuous glucose monitor, which about 90% of our patients are using those, that reads out the sugar number on your phone or your pump.
Now, that didn't exist.
No, it's
long
really
ago. I mean, I feel like when I was volunteering in the camp, not many kids had continuous glucose monitors then.
Exactly. They were just really emerging around 2010 in terms of the first pediatric trial. You know, that came out in like 2008. But then it's really that the technology has gotten so good, so easy to use, and is reading out on smartphones. So it's really been in the past 5 to 10 years that it's taken off. Now, if people are using a continuous glucose monitor, it is possible for the insulin pump to talk to it. So that, for example, let's say that muffin was a total mismatch. They had the carb count wrong, or you didn't give the insulin ahead of time, or something happened and your blood sugar ended up 300.
Too high.
Too high. That's too high. You could add extra insulin without the person doing anything, just because the pump's talking to the sensor. It can help bring those things down.
So it knows how to almost auto-regulate?
It auto-regulates, exactly. It doesn't replace, at this point in time, the person counting their carbohydrates and covering their food with insulin, but it does make it easier. And especially overnight when they're sleeping and there's not a lot of interference from food, the glucoses can really get beautifully regulated by these systems.
That's really incredible. And I imagine as the technology gets better, then that regulation between the monitor and the pump can get better and better.
Exactly. It's all about the technology. What's happening is type 1 diabetes is becoming a condition in which a lot of people are wearing devices. And you see them out there. You see them even in Inside Out 2 had somebody with diabetes where they were wearing a glucose sensor.
I haven't seen it yet, so don't tell me too much.
There's this store at the mall that I saw where they had a model in the window wearing a glucose sensor.
I love that from just a awareness. We all have different things, and some of us wear pumps. I love that.
I think it's awesome. It's important to remember, though, that with these devices comes barriers with wearing them.
Yeah.
And then also some people don't want to be on them, and that's okay. It's our job to help empower them to make a decision that's right for them. And if they want to be on injections, to help make that work. But the final piece is just that it's becoming a condition with type 1 diabetes where there's so much literacy required, Bluetooth, Wi-Fi, connections between devices, a lot of logistics, a lot of supplies, and we're focusing more and more on healthcare disparities and trying to make sure that everybody has access to these things. Unfortunately, it's a condition in which some sophistication is required, and we need to empower families to be able to take care of it.
So it sounds like that's where teaching and education is key, but also access to technology and the tools and providing that optimal treatment for that individual and their family.
Yeah, exactly. The goal is to keep the blood sugar in range for as much of the time as we can. And so our job is to help people find the right devices to do that, to get those devices covered by insurance if that's what they want, which requires a lot of support from insurance companies and administrative staff to help us with authorizations, and then to provide the education, no matter what the regimen is, to really help them do what it is they need to do and also feel like the burden of care isn't too much. Because that's the other thing. There's the
emotional
glucose outcomes. Yeah, there's the blood sugar outcomes. But then another outcome that I talk about with my patients all the time and their families is, how's it feeling to you to take care of this day in and day out? And if your glucoses are exceptional and you're feeling like that burden is too much, then we're not doing what we need to do. We need to have both of those things be okay.
Yeah, I mean, just like any disability or chronic health issue, it's not something that goes away. You don't get a vacation, and it's something that you always have to be managing and dealing with and figuring out how it's going to work for you. And that's a lot for anyone.
Yeah, it really is. And just to go back to diabetes camp, you see the intensity of management, just everybody gathering around at meals to get the insulin dosed, doing their device changes with their peers, setting up stations to treat low blood sugars, because it's inevitable that you're going to overshoot in type 1 diabetes.
So meaning the insulin drops your blood sugar too low?
The insulin drops your blood sugar too low, and that's a really common scenario. Part of life with type 1 diabetes is going low. And so at camp, they have stations set up to treat those with juice or glucose tablets or whatever. And it's just amazing to see that normalized for people.
And that resiliency that the kids have. And to be able to be a part of camp, I can only imagine it helps them to feel like they found some other kids who are going through the same thing. And that must be such a positive experience. I do that with my kids. So they go to Scales Camp, and it's just phenomenal.
Yeah, it's so funny because my child who doesn't have diabetes was there with me the most recent time, who is 8 years old. And he was saying it was so strange being the only one in the cabin who doesn't have diabetes. Well, this is what they all have the rest
all the
of the
time.
year.
Exactly.
Right. Yeah. So.
What happens, or how do we know when a patient is not having their diabetes well managed?
Yeah, great question. So the first thing that may be helpful to go over is just how do we track management of diabetes? And one thing is that hemoglobin A1C test that I talked about earlier, which tells you about the exposure of the red blood cells to sugar. We check that at every visit, and we have targets for people living with diabetes. And so we can provide people with feedback on how the glucoses are in range or not in range and help make a plan to bring them down. Now, with continuous glucose monitors, we actually can calculate for a week, 2 weeks, a month, 3 months, the percent of the glucoses that are in range. And so I tell my patients, if I see you on the street and say, what's your time in range? I don't want a blank stare. I want engagement with the number, like, oh, it was 40% when I saw you in clinic, but I'm really happy because now I got it up to 50. The reason why we have targets for A1C, for time in range on CGM, is because over time, there is a risk of complications from chronic exposure to high blood sugars. What happens is that in the places in the body with tiny blood vessels, the damage from the high blood sugars is most prevalent. So the eyes, the kidneys, the nerves in the feet. You hear about diabetic blindness or kidney failure or amputation. Those would be extreme examples.
Pretty serious.
And what's so hard in pediatrics is that those things aren't going to happen during our care of the patient. And so how do you help someone who's a teenager understand that if this level of high A1C, low time in range, not giving insulin when they eat, if that continues, maybe when they're in adult care, they might have some of these complications starting to develop, but it's not generally a pediatric problem to see the complications. It's all about prevention.
So your goal as a pediatric endocrinologist is to set up that teen, that child, that adolescent for success later in life.
That's exactly right. And what can be so challenging is that diabetes can often feel okay in the moment. People can almost get sensitized to having high blood sugars and feel pretty good, but they're going to have problems. And how do we approach those conversations? How do we find ways to motivate people? I find that often it helps to find things in the here and now that can be a little bit easier than saying, when you're 40, we're going to have an issue. If you are 16 and you want to try to make varsity and you're trying to do that with your blood sugar really, really high, you're not going to perform well. That's going to get more and more apparent the deeper you get into your sport. And so athletes are often easy for me because I have something I can focus on, to provide counseling.
And a lot of kids obviously like athletics. So, and if it's not athletics, if you're like me, could be like, you want to do really well in school, right? So
exactly.
The brain's got to work too.
No, and that's right. There is clear evidence of academic performance being more challenging at either the low end or the high end of the sugar spectrum. And so that's another big one for me.
Yeah, that makes sense. Well, thinking about all the complexities in care, I was wondering if you could talk about all the different folks that are involved in caring for kids with diabetes and maybe specifically talk about how unique our program is here.
Pediatric diabetes is 100% a team sport. You have to have people approaching it from different angles. And for us, that includes the endocrinologist. Also, an incredibly important part of the team is the diabetes nurse educator who really develops that close relationship with the family, does all of the device training and education in the long term, and really works closely with the doctor to provide that education. Two more important aspects to think about are nutrition and mental health. So for nutrition, there's so many things to consider. How do you count carbohydrates in the foods that you're eating? How do you understand that different things are going to affect your blood sugars differently? Helping people to understand how important healthy eating is and providing that education is critical. So the dietitian and complicated. And then the mental health, of course, the emotional impact of this is large on the person living with it, on the family. As a mom, you're always worried about the blood sugar going low or going high. Now we have these monitors, but you're still worried about alarms going off and will you hear it? What's happening? And so there can be a lot of parental anxiety and anxiety about the logistics and diabetes burnout. We have mental health providers here at Boston Children's to meet with families as well and really provide that expert mental health support. One of the special things about our program is also that we do a lot of group programming from different angles, mental health, nutrition, education, but also opportunities for people to do family advisory committee or teen advisory committee or various support groups or social media connections.
Oh, that's fantastic. Even social media can be a conduit to bring families together so that they can have that mutual support. It just reminds me of the importance of community. That's fantastic. So One of the things you mentioned is some of the implications for athletes. And what about just in general? How does physical activity impact the care of kids with diabetes?
Yeah, that's a great point. Even just walking or going out to recess, these things all need to be balanced. So in type 1 diabetes, we're replacing insulin and we do the very best we can, but it's not perfect. The human body puts out insulin in a way that is perfectly matched to the circumstances, and it can be put out right into our blood vessels, and then it can be gone. So short acting. And the insulin that we give, we put it under the skin. It takes time to hit. And then once it hits, we're stuck with it. Even with the fastest insulins we have, they're around for a few hours and you can't get rid of them. And exercising makes you much more sensitive to insulin. And so how do you strike that balance between giving enough insulin for food and not going high, but then being able to exercise without going low? And so that is the issue. And there are different kinds of exercise that are more likely to make one drop low. For example, ones that are very adrenaline based, like ice hockey, where you're out there checking people. You might have adrenaline and that kind of counteracts the insulin a little bit and you tend to stay a little bit higher. But things where you're just going for a run or kids just playing outside, they can tend to drop. And so these new devices that we have that read out the number all the time can be really helpful because you could try to get ahead of it. But really, it comes down to understanding your body, and no two people are exactly the same, and understanding how exercise affects you and how you can match the insulin as best you can so that it's enough when you need it and not too much when you don't.
Wow.
And it's a real tightrope act. Yeah.
There's a lot to think about.
There is.
Turns out that the pancreas is a pretty smart organ when it works.
I think that's what I've always found so fascinating is that you just have one problem. You take out one cell in the body.
Wow.
And yet giving that function back is something that is just so extraordinarily difficult to do. And we just try to help people do it as well as they can.
Well, having said that, I imagine that this has a big impact on our kids and their parents' sort of emotional well-being. So how do you recommend supporting our kids' emotional well-being when they're trying to manage all of this all the time?
A really important part of emotional support is teaching kids with type 1 diabetes that they can do whatever it is they want to do. We just need to plan for it and bring people into the circle of trust. So coaches, teachers,
maybe friends if they're older.
Parents of friends.
Yeah.
So you feel like you can go over to a friend's house and you have parents who are willing to learn a little bit about it so the kid can do that.
That's so important. And I love what you said. It's important to help the parents and the kids know that they can do anything that anyone else does. We have to figure out how to do it and be prepared.
That's exactly right. My child with diabetes, who is now 16, is about to go on an international service trip. And even I, with all of my experience, find the logistics of that like absolutely daunting. Just how many supplies do you need? And who needs to know about this? And how can we set this up for success?
So important, but it's doable, right? It sounds like good luck. And I hope your son enjoys the upcoming trip. That's so exciting.
Yeah.
So as we get near the end of our conversation, and I'm just going to say I've thoroughly enjoyed and learned so much from you today, I always love to ask, what's on the horizon from a research perspective?
We are at actually a really important crossroads moment in type 1 diabetes. Until now, insulin has been the only thing that can be used as a treatment for this disease. And now, due to amazing research going on, there are going to be two other areas to add to insulin replacement. One is immune therapies to affect the underlying process that is destroying the beta cells. Now, that would involve catching it early enough.
Yeah, because you have to prevent the immune response, right?
Exactly. And if you're too late, then they're all destroyed. And so the immune therapy is not going to do anything. So there are immune therapies on the horizon. There's one that is FDA approved, and Boston Children's is one of the first centers to really be able to implement this in clinical care. It's Tzield, and it's a therapy where if we can find that someone is at risk for getting diabetes soon, they have positive antibodies, they have early abnormal sugars, but they don't yet have diabetes, they haven't crossed that line, you can give this treatment and have it be delayed by up to a few years.
Oh my goodness.
Which
Wow.
is a really interesting question. So how do you catch people at that moment? Right now, it's a lot of screening family members, but as we know, a lot of people with type 1 diabetes don't have anyone in the family. And so it raises really interesting questions about who's going to get screened screened for this? And at what point would the immune therapies be good enough and accessible enough that we would start screening everybody? So that's a really interesting question, but that's something that is on the horizon and will likely move into also being approved for people who were just diagnosed. So who may have diabetes, but still have some beta cells left. And if we can protect those beta cells and keep them going for as long as we can, would that make their diabetes easier in the long run? So they might have to take some insulin, but not as much. The blood sugar roller coaster wouldn't be as much. They would be less likely to have complications later, that kind of thing. So immune therapies are one bucket. But then what if you've had diabetes for over a decade, like my son? There are no beta cells left. What do you do for the hundreds of thousands of people in that situation? And the answer would be stem cells.
Stem cells, for our audience, if they don't know, these are cells, right, that are so early on in their developmental stage that they're capable of becoming almost any part of your body.
Exactly. And they figured out through research how to take stem cells and turn them into beta cells. So that is being done. A key question is, how do you get that to a point where you can protect them from the immune system so you don't have to give people drugs like you would for a transplant to suppress their immune system, because they all have an autoimmune disease.
So you have to, not only can you think about replacing those beta cells with stem cells, but you also need to protect them with some type of an immune modulator or shield.
A shield.
Yeah.
So that's all being worked on. And so
it's amazing, though.
It is amazing. And I believe that in the next 10, 20 years, we are going to have major options for both the immunologic and the cell replacement treatment, where insulin replacement will be a big part of what we do, but not the only part. And once you talk about cell replacement, you're really moving towards talking about a cure.
Yeah.
And so then the question becomes, how does that look when you have a disease that affects so many people? And how is that going to roll out? And how's that going to affect healthcare disparities?
How do you prevent, right, inequity, and how you roll something like that out?
So that's what I really enjoy thinking about, is the healthcare disparities piece for everything, for devices, for treatment and education, but then also with these new therapies. I foresee some real issues there, just given the sheer size of the population. And I enjoy thinking about ways we could be proactive about that.
Yeah, and make sure that all kids have access.
Exactly.
That's pretty exciting, though, to think about.
Yeah.
Well, it's been so fun chatting with you. I've learned so much. As we wrap up, is there anything that we haven't talked about that you want to make sure we share with our audience?
No, I think we've covered a lot. I've loved talking to you too. I think, just to go back, my expertise and the large part of my clinical practice is in type 1. But I just want to go back for a minute to type 2. It's less frequent in kids than type 1, but it's so serious. If somebody develops type 2 diabetes at the point of being a teenager, then really we're looking at a long time that they're living with it. And it's associated with a lot of health effects that we worry about in adults.
It's another important topic. Now it's time for doctor's orders. And this is where we ask you, as an expert, to share some advice that our parents can take action on to help them raise healthy and happy kids. So what are your doctor's orders?
First of all, I hope we've raised awareness so that if you come across a child or a family dealing with diabetes, that you have a little window into what that's like. But I think my doctor's orders would be, just don't miss the signs and symptoms of diabetes. Remember, frequent urination, frequent thirst. These things can fly under the radar, but if you catch the signs, you can really prevent somebody coming in with a new diagnosis of diabetes very sick. So don't miss the signs.
Yeah, so awareness is key. Thank you so much. I know our audience has learned so much, and it's just hopefully going to help more parents raise healthy, happy kids.
Oh, thanks, Dr. Arnold. It's been such a pleasure being here.
Thank you.
Of course.
Thanks again for listening to Boston Children's Answers Parentcast. And a special thanks, as always, to our parent guest, Mary, and our guest expert, Dr. Garvey. You all know that we've been on the air for a while now. So if you've missed some of our earlier episodes or you want to keep listening to our future, check us out at bostonchildrens.org. Thanks again, and see you next time.